5 medical checkups I'd never get after 65. The landscape of healthcare for adults over 60 is often misunderstood, leading to well-intentioned medical interventions that can sometimes do more harm than good. Dr. Franklin, an expert dedicated to demystifying health research for this age group, presents a compelling case for a more discerning approach to routine medical screenings. He emphasizes that while medical advancements are invaluable, their application must be tailored to the evolving biological realities of aging, a consideration often lost in the efficiency-driven pace of modern medicine. The core message revolves around a concept he terms the longevity lens, which fundamentally shifts the benefit-risk analysis of screenings after a certain age. This lens acknowledges that conditions detected in older adults might be slow-growing, asymptomatic, and unlikely to impact longevity, yet medical systems are often programmed to treat rather than observe. Furthermore, the body's capacity to tolerate interventions diminishes with age, meaning procedures that are routine for younger individuals can carry significantly higher risks and longer recovery times for those over 70. This can initiate a cascade effect where an initial, potentially unnecessary test leads to a series of further investigations and treatments, escalating into a complex and stressful medical journey for someone who was previously feeling quite well. Dr. Franklin's aim is to empower individuals over 60 with knowledge derived from extensive medical literature, enabling them to engage in more informed conversations with their healthcare providers and prioritize quality of life. The first checkup Dr. Franklin advises reconsidering after the age of 75 is the routine colonoscopy for average-risk individuals. He illustrates this with the story of Dorothy, a 77-year-old who experienced a severe reaction to the bowel preparation for a colonoscopy, leading to hospitalization for dehydration and electrolyte imbalance, and ultimately the procedure was never performed. This highlights a critical point. The preparatory stages of some tests can carry significant risks, particularly for older adults. The United States Preventive Services Task Force, a leading authority on screening guidelines, now officially recommends against routine colonoscopies for average-risk adults over 75. The evidence indicates that after this age, for individuals without symptoms, a family history, or previous concerning results, the potential harms of a colonoscopy, such as a bowel perforation, estimated at 1 in 500 procedures, can outweigh the benefits. The cancers most likely to be detected in asymptomatic older individuals at this stage are often slow-growing and may never cause problems within their remaining lifespan. Instead of routine colonoscopies, Dr. Franklin suggests non-invasive stool-based tests like Cologuard or the annual FIT test as effective ways to detect genuine warning signs without the procedural risks. Of course, if symptoms like blood in the stool or unexplained changes in bowel habits are present, a prompt medical evaluation remains crucial. This nuanced approach prioritizes minimizing potential harm while still ensuring appropriate detection of serious conditions. Next, Dr. Franklin addresses aggressive prostate cancer screening, PSA testing, and annual mammography for low-risk patients, emphasizing the issue of overdiagnosis and overtreatment, particularly after the age of 75. He clarifies that he is not advocating against cancer screening entirely, as it has undeniably saved countless lives. However, he points out that modern imaging technology is so advanced it can detect extremely small, slow-growing tumors that are biologically barely awake, tumors that would likely never spread, cause symptoms, or shorten a person's life. The problem arises because once such a malignancy is noted on a report, the medical system is inclined to intervene. This can lead to biopsies, specialist referrals, and treatments, regardless of whether the detected cancer poses a genuine threat. The story of Richard, a 79-year-old who underwent radiation therapy for low-grade prostate cancer, serves as a cautionary tale. He experienced a significant decline in his quality of life due to chronic fatigue and urinary problems, and looking back, he wished he had understood that his cancer was the type that he would likely have lived alongside rather than died from. Similar findings exist in studies concerning mammography in women over 70, where a substantial portion of detected cancers were found to be clinically insignificant, meaning treatment offered no survival benefit but did carry side effects. Dr. Franklin advises an honest discussion with one's doctor about individual risk profiles. For those with average risk and no symptoms, he encourages asking directly about realistic treatment options at their age and what a likely recommendation would be if something is found. This proactive questioning can fundamentally alter the clinician-patient dynamic. The third checkup Dr. Franklin suggests reconsidering is routine cardiac stress testing in individuals without symptoms. This recommendation often surprises people because it seems like a logical and responsible measure to ensure heart health in older adults. The concern lies in the high false positive rates of cardiac stress tests, which can reach 40% or more in certain older populations. A false positive means the test flags an abnormality when the heart is actually functioning perfectly well. However, medical protocols do not allow for ignoring an abnormal result, which then often leads to a cardiac catheterization. This invasive procedure involves threading a thin tube into the heart and carries risks such as bleeding, vessel damage, arrhythmias, and, in rare instances, can even trigger the very cardiac event it was intended to detect. Furthermore, if the catheterization reveals a partial blockage, which is very common in adults over 70, many of whom are asymptomatic, the patient may be recommended for a cardiac stent. Crucially, landmark clinical trials like the ischemia trial have demonstrated that stenting in patients with stable coronary artery disease does not significantly reduce the risk of heart attacks or extend life compared to managing the condition with medication and lifestyle changes alone. The stent itself introduces risks, and the patient then faces a lifetime of blood-thinning medication with its own set of potential complications. Therefore, an individual might undergo a series of interventions and end up no better off statistically than someone who simply managed their condition through medication and healthy lifestyle choices. Dr. Franklin advocates for focusing on optimizing modifiable risk factors like blood pressure, cholesterol, blood sugar, activity, and sleep, which offer more substantial and less risky gains for heart health in the absence of symptoms. Number 4 on Dr. Franklin's list is the routine bone density DEXA scan, particularly when it automatically leads to medication prescriptions. He acknowledges the reality of bone loss with aging and the serious consequences of falls in older adults, but he questions the automatic progression from a DEXA scan result to long-term medication, such as bisphosphonates. These medications, while intended to strengthen bones, have been associated with rare but serious side effects like atypical femoral fractures, spontaneous stress fractures in the thigh bone, and osteonecrosis of the jaw. What is often overlooked, according to Dr. Franklin, is that the most effective intervention for preventing fractures in older adults is not a pill, but fall prevention. This includes crucial measures like balance training, with studies showing Tai Chi can reduce fall risk by nearly 50%, removing tripping hazards from the home, installing grab bars, reviewing medications for dizziness-inducing side effects, ensuring regular vision checks, and maintaining adequate protein and vitamin D intake. These non-pharmacological interventions can significantly reduce fracture risk with no adverse effects. While acknowledging that medication is necessary for some individuals, such as those with a history of fractures or very low bone density scores, he stresses that a routine DEXA scan for a healthy, active 74-year-old who has never broken a bone should not automatically result in long-term medication. Instead, it should be a starting point for a conversation about fall prevention strategies and a thorough understanding of the medication's actual fracture risk reduction compared to a comprehensive fall prevention program. Finally, Dr. Franklin highlights asymptomatic carotid artery ultrasound screening as a procedure that receives little attention but can have profoundly negative consequences. A carotid ultrasound checks the arteries in the neck that supply blood to the brain, with the intention of identifying blockages that could be surgically cleared to prevent strokes. While this logic appears sound, the reality for asymptomatic individuals is far more complex and potentially dangerous. The surgical procedure to treat a carotid blockage, known as carotid endarterectomy, carries a significant risk, 2 to 3%, of causing a stroke during or immediately after the surgery, a risk that can be even higher in older adults with other health conditions. The United States Preventive Services Task Force explicitly advises against routine carotid artery screening in individuals who have no symptoms of stroke, transient ischemic attacks, TIAs, vision loss, or other neurological issues. Their analysis concludes that in asymptomatic patients, the risk of surgical harm outweighs any potential benefit. The issue is that many individuals over 70 have some degree of carotid artery narrowing that has been stable and asymptomatic for years. When routine screening detects this, a surgeon might recommend intervention. However, the surgery itself can dislodge a small piece of plaque, which can then travel to the brain and cause a stroke, the very event it was meant to prevent. Dr. Franklin emphasizes that documented outcomes in the medical literature show individuals undergoing such screenings and subsequently experiencing devastating neurological events, not from the pre-existing blockage, but from the intervention itself. Instead of routine screening, he advocates for focusing on managing modifiable risk factors like high blood pressure, blood sugar, smoking cessation, managing atrial fibrillation, and maintaining physical activity, which are the most effective ways to prevent strokes. Prompt medical evaluation is crucial if any stroke-like symptoms, even brief ones, are experienced. To equip individuals with the tools to navigate these discussions, Dr. Franklin presents a practical 5-question protocol to be used every time a screening test is recommended, especially for those over 70 and feeling well. These questions are designed to shift the focus from simply detecting abnormalities to understanding the real-world implications for quality of life. The first question, what is the false positive rate of this test in people my age? Aims to ascertain the likelihood of receiving an inaccurate result that could trigger unnecessary follow-up procedures. Second, if this test finds something, what are the realistic treatment options for someone my age and health status? Encourages a conversation about outcomes and interventions tailored to the individual's circumstances. The third, what is the procedural risk of any treatment we'd likely pursue, is a critical, often overlooked question, as every medical procedure carries inherent risks. Fourth, what happens if we monitor this instead of treating it? Opens the door to considering watchful waiting, an often appropriate and superior strategy for many conditions found in older adults. Finally, what is the most effective, non-invasive intervention for this condition? Prompts exploration of lifestyle or less invasive options, which frequently offer better results with fewer risks, particularly for issues related to bone health, heart health, and stroke prevention. Dr. Franklin asserts that any competent physician will welcome these questions, as they demonstrate patient engagement and a desire for informed decision-making. Conversely, if a doctor dismisses these questions or makes a patient feel difficult for asking them, it serves as valuable information about the suitability of that physician. He concludes by differentiating between medicine that finds things and medicine that helps you live well. After 70, the paramount goal of healthcare should be to protect and extend quality of life, independence, energy, and the ability to engage in meaningful activities, rather than simply generating medical findings. The wisest physicians understand that doing less requires more wisdom and courage than doing more. Patients have the right to understand the purpose of a test, the consequences of a finding, and whether any subsequent treatment will genuinely improve their lives. Medical tools are most effective when used appropriately, considering the individual's context, timing, and personal goals. Dr. Franklin encourages viewers to subscribe for more practical, evidence-based health information and to share their own experiences in the comments, as these stories can profoundly help others.